Hello, it's Miss Marcum, and today we're going to talk about ow! Oh, pain. Many of your patients are going to have pain, so this information is extremely important. Acute pain. Acute pain refers to a new onset of pain, and it is understood why there is pain. It typically will last less than 6 months. It is localized generally and well defined. With acute pain, the pathways for pain are rapidly conducting. There's heightened sympathetic nervous system activity, so that's going to be that muscle guarding, where there'll be the muscle contraction as a way to protect the injury. The heart rate will go up, the blood pressure will go up. You'll see these things when you monitor people's vital signs when they are experiencing pain. To treat it, we must reduce inflammation, as we need to get them out of that stage to progress further through the other stages of healing, so the pain can subside and gradually go away. Chronic pain can start as acute pain, which could be because of disease or injury, or pain that has no identifiable cause. Chronic nociceptive is considered things like arthritis and cancer. Neuropathic pain is diabetic neuropathy, phantom limb syndrome, things like that. Mixed pain syndromes, these will have uncertain pathophysiologies or multiple pathophysiologies, things like recurrent headaches. Chronic pain can also be psychological. There could be no apparent damage or reason for why they have this pain, but the pain is very real to the person. There are so many types of pain. Do somatic pain and visceral pain feel different? Yes, they do. Somatic pain comes from the skin and the deep tissues, but visceral pain comes from our internal organs. What are nociceptors? Nociceptors are pain detecting nerves. They send an impulse from a painful site up through the spinal cord to the brain for interpretation and reaction. I stepped on a nail. I'm going to pick up my foot. This is called nociceptive pain. It differs from neuropathic pain. Nociceptive pain is nothing more than our body's ability to recognize painful stimulus. But neuropathic pain is it's a chronic condition, and it's usually a result of tissue damage. So the nerve fibers themselves could become damaged. They could be dysfunctional, firing improperly, or just injured. And these would be sending incorrect pain signals. That's what neuropathic pain is. Referred pain. When you think about how the nerves are laid out in the body, you will recognize that they all converge onto these master highways, so to speak. And so peripheral neural pathways from different areas of the body converge onto these same or similar areas of our spinal cord, and their signals will synapse with the same neurons that will ascend the spinal cord to reach the central cortex. So therefore, when you think about it, it makes sense that visceral pain can be interpreted as musculoskeletal pain in its origin. So how do you think we as therapists could differentiate between musculoskeletal pain and visceral pain? I'm just going to take you through a thought experiment and, just see where it takes you. So I come in and I'm complaining of pain in my right shoulder. I come into your clinic, fix me, my shoulder hurts. How would you know that this pain that I'm experiencing is musculoskeletal versus visceral? Go ahead and pause the lecture and take a moment to think about that. It's a little early to try to problem solve this possibly in your education, but basically, you would simply move the shoulder. If the pain doesn't increase with movement or having them do active movement, then chances are it's not musculoskeletal in origin. At some point, there should be more pain with some sort of activity if it's a musculoskeletal pain. So if you move the shoulder around in all directions and there's no increase in pain, there's nothing else that's showing there, then there's an attempt that it could be visceral pain that's being referred to the shoulder. And then we would refer them to a physician. Visceral pain won't respond to or increase with movement of that musculoskeletal place where it is being referred to, but visceral pain can increase when there's stress that's put on that system that is referring the pain in the first place, the affected system. Let's take a look at the pain, spasm, pain cycle. This is a spinal cord reflex, which means it doesn't involve the brain. It's a self-perpetuating cycle. The nociceptors, which are the pain receptors in the body, activate the interneuron, and that causes the muscle to contract or spasm. These muscle contractions or muscle spasms can also initiate further nociceptive impulses by mechanical compression of those nociceptors. So that's why it's self-perpetuating. There becomes this muscle spasm, and then as the muscle forcefully contracts down on those nociceptors with mechanical compression, they fire again. It goes back up to the spinal cord, and it immediately shoots back the pain signal to have the muscle contraction or the muscle spasm, and it just repeats itself ad nauseum. It never goes up to the brain for interpretation. Well, how do we stop that kind of thing? We actually have several ways that we can do that, and you'll learn more about that as you go through rehab and procedures. Here are some pain control measures that I will talk about, and those are going to be our non-narcotic analgesics as well as the narcotic style. Chemo and radiation therapy can have pain controlling measures. Surgery can help, surgeries maybe that work on nerve decompression or just, surgeries that fix the thing that's causing the pain. And then nerve blocks as well. And you'll learn more about nerve blocks in the skills class. Those can be interesting. They do a great job at blocking pain, but they also block the motor control as well. So people feel fine, but if they've had like a knee surgery, their knee will just buckle and give out on them until the nerve block wears off. So those are some methods there. And if you had had procedures already, you would recognize that something is missing from this list, and that is modalities. And that's one of the interventions that physical therapists and physical therapist assistants have to help patients deal with muscle spasms and manage their pain at home. So modalities would also be appropriate to have on this list. It's not listed here because I like to ask the class what's missing from this list so people can call out the modalities that they've learned. But since you haven't had that yet, I'll just give away the answer. Okay, let's talk about medications. One of my least favorite topics, but it's important to know. Tylenol is used for mild pain when there is no inflammation treatment needed. Otherwise, NSAIDs or steroidal anti-inflammatory drugs would be used for pain with inflammation. There can also be muscle relaxants, and those are used for pain because of muscle spasms. NSAIDs are pretty useful. They are used for inflammation, fever, as well as pain, and they're sold over the counter. Here is a list of some of the common ones that you are probably familiar with, and you are responsible to know what some NSAIDs are. And here we have the common side effects of these NSAIDs. They can be found in Table 2-1. For all of you overachievers out there or rabbit hole chasers, we are not going to discuss the mechanisms behind the side effects of these drugs and how they produce these negative side effects. You only need to know what these negative side effects are. Remember, we do not deal in medication, but we do deal in the patients who take them, so we have to be aware of how they affect our patients. Let's take a look at this list of side effects. Dyspepsia. So that's essentially pain in the upper abdomen for indigestion. They also may get nausea, vomiting. NSAIDs frequent use can cause GI bleeding as well as ulcerations, so long-term use is bad. Central nervous system involvement can cause drowsiness, dizziness, things like that. And you'll see that it has renal system involvements as well, such as sodium retention, which can cause generalized edema. It can increase the blood pressure and even lead to hyperkalemia, which you've heard about before. And if you don't remember what it is, go look it up. Liver, it can affect the liver enzymes and induce jaundice. Muscle relaxers. These are used a lot to treat muscle pain and muscle spasms. The thing is they will relax the entire central nervous system and they will provide an overall muscle relaxation. Therefore, they are used for short-term control of muscle pain, and the common side effects, as you could imagine, would be drowsiness, dizziness, feelings of fatigue and lethargy, and of course this can lead to dependence as drug dependence. Every year when this list of common muscle relaxers comes onto the screen, someone asks if they have to memorize all these names. And again, we're not nurses, so I'm not going to make you do that. But looking at this list, I can tell you that there are so many here that I've heard the name of multiple times. Therefore, I am going to tell you which one of these to highlight down this list, and you are responsible to know that medication's name because I know you're going to hear it and you're going to see it in the medical record. So we got baclofen, Flexerol, Soma, Robaxin, and Valium. I want you to definitely know those names for muscle relaxers. Nerve blocks. These are delivered by an injection to a localized area. It can happen once or multiple times, and sometimes they will even put on a pump that allows for continuous injection for a short period of time. The main purpose in a nerve block is to reduce the need for the patient to need narcotics while they're recovering. But as I stated earlier, it also blocks the motor function, so they will have a tendency to have their knee buckle if it's a knee surgery, which is in most situations where I've seen it. In fact, nerve blocks are most commonly used with orthopedic surgeries. So these patients who are on nerve blocks, especially the ones that go home with a injection where it continues to provide some continuous injection, it's like a little pouch that they'll wear around like in a sling around their body, and they'll leave a tube inside the knee for the injection. So anyway, they go home with a knee brace because if they walk without the knee brace, chances are they're like a buckle on them. So that's the downside of nerve blocks, but in most cases what I've seen is they give it one time for the surgery. So while they're in there, the surgeon will give the nerve block and maybe add another pain medication with it as well. And then the patient wakes up and that nerve block is still in effect, and it will be in effect for about 24 hours. So by the time the patient is about ready for discharge, because most people are only in the hospital for one night and they are out within 23 hours from their surgery, these patients tend to be recovered almost most of their knee function, and they're safe to go home with a less risk that the knee will buckle on them. Here's a list of 3 of the medications that they say are commonly used. I've only seen the lidocaine, but I'm sure there are many. These other ones are just as common. I think it depends on the hospital you're at. Narcotics specifically come from poppy plants. They are all opioids. And we have opioid receptors in our brain, and they bind with them to very successfully block pain. However, they can lead to physical and psychological dependence, so they try to use them more carefully these days. This medication is reserved when the non-narcotic analgesics are not strong enough to help manage the patient's pain. Here we have another list of names that might induce some sort of panic, but some of these you should really already be familiar with. So once again, I'm going to tell you the ones that I've come across frequently in the hospital, and these are the ones I would expect you to be able to identify yourself if I was your clinical instructor and you were sent to me to be my student while at the hospital. Morphine, codeine, fentanyl, oxycodone, and Tramadol. You will see all of those. All these medications will come with side effects, and opioids definitely have their set of them. So we've already talked about the addictive nature of them. And just like most of these medications, they're going to cause drowsiness. And they can also, this particular one can cause nausea and vomiting. It's very upsetting to the stomach. And you'll see on this list meiosis, which may be a term that you're unfamiliar with, and that's just constriction of the eye, the pupil of the eye. And it causes constipation because opiates just slow time and they have an effect on the GI tract. So it just slows the GI tract down. So a lot of time people have to take stool softeners in order while they're also on the opiates, so they can go poop. Moving along, let's talk about psychological disorders. You will often hear us say you have to look at the whole patient. And what exactly does that mean? It also incorporates thinking about who they are as a person and psychologically where they are currently at and where they have the potential to go. So far, the focus that we have had has been on the context of what is physically wrong with them. But we also need to explore the whole human. What is going on? What's their emotional experience behind their condition? And this is a time we're going to dive deeper into this topic. And this is something I feel very passionately about. My first degree is in psychology, and I find it's really important to kind of be a chameleon when it comes to personalities in the healthcare profession. You have to figure out who they are and how they can best respond to you. And it can often be about morphing and acting who we are in that moment in order to get the best results out of the person that we are working with. And I'm comfortable with that. Like, I can be my own self outside of work. I can be weird and say the things I believe but at work, none of that is my role. It is always my role to figure out how I can best get this person to listen to me as far as what's good for them physically and to help them recover and regain their independence and keep their dignity as a person. This is the lecture where I harp on about acceptance, accepting who they are, accepting that they don't have to like you, accepting that you don't have to like them, accepting that your role is to help them, and accepting that thing about our personality that we should prize over everything else when we're interacting with people who are going through so many different situations is our compassion and our ability to put our own stuff aside to be compassionate and accept them for who they are in that moment. Psychological considerations in healthcare. Psychological considerations in healthcare. How do we increase patient compliance? That is part of your job. We need to find out what is important to our patient. Here are a string of rhetorical questions I want you to take a moment to explore. In a time of physical crisis, what becomes important to you? What do you value? How do you feel? Is this when the best or the worst of your personality comes out? What are some of the things that your patients might be feeling in their time of physical crisis? Fear. Have I just lost my college scholarship because I tore my rotator cuff? How am I going to take care of my toddler? Will I ever use my arm again? Am I ever going to walk again? Uncertainty. How will my life look going forward? What is my support system like? Do I have family and friends who are really going to be there for me? spirituality. Will my religion sustain me? Will my philosophy sustain me? And what do you think our role is? We are not psychologists. I am not a psychologist despite my bachelor's degree on it. I just find it interesting. But psychology is a whole other field, and we are not trained to treat psychological disorders. However, we may be uniquely positioned to recognize that our patient might need psychological support. And we could be someone who refers them and encourages them to seek that out. For example, when I work in acute care, I would work with a patient who was maybe newly diagnosed with cancer, or maybe they were very far along in their chronic illness and they knew they would be dying soon. In either situation, mentally, they were responding poorly. And I would just talk to them for a little while and figure out what they cared about. One woman made it clear to me pretty much immediately that she was deeply religious and, she wanted to pray, and you can be there for them, but we don't get paid to pray for a long amount of time with our patients. But what we can do is speak to them about the pastor at the hospital or at the skilled nursing facility, or maybe encourage them to call their pastor on the phone. But we can encourage them to reach out to that support system that means something to them. And so I referred many patients to the pastors, to our psychological counselors, our psychiatrists, and things like that at the hospital, because I just recognized that they needed it. And I would talk to them, they would be open to it, and then I would update the nurse, and she would talk to the doctor who would set up the referral. So it's all about that group of people working together for the patient and recognizing everything that they need. Abuse. There is no way to identify somebody as from outward appearances if they are just a survivor of domestic abuse. Perpetuators are also very good at covering it up. And survivors of the abuse desperately want their lives to appear normal, and they will also sometimes work to cover it up. What happens is there can be these repeat visits to the hospital, and over time, I'm an actor, darlings. Over time, that helps build trust between that patient who's a survivor of abuse and the care team that takes care of them. And they may open up to their nurse or to you as their therapist when an opportunity permits. So at that moment, it's our role to listen. We would redirect them to and encourage them to reach out to the people that can help them and let them know that that's what we would like to do. So we're going to refer them to help, and we're going to educate them about all the services that our hospital or facility provide that can help them out of that situation. It's also important to keep in mind that victims don't always recognize their abuse. Abusers can be insidious. They can slowly work and ramp things up over time, and the abuse can start to feel normal. I briefly mentioned that patients can experience physical pain because of a psychological root. Unless the problem, that underlying condition, is addressed, their pain may never fully resolve. I have some statistics to put it into perspective. Nearly 900,000 children, or 12.3 per 1,000, are identified as victims of abuse or neglect in the United States. More than 500,000 elderly over 60 are abused or neglected annually. 1.5 million women and 835,000 men are raped or physically assaulted by someone close to them each year. There is a conservative estimate of 2 million episodes of domestic violence each year in the United States, but the estimate is probably closer to 4 million. 8% of men and approximately 20% of women develop PTSD or post-traumatic stress disorder after a traumatic event, and there's about 5.2 million adults who experience PTSD every year. The incidence is higher for those who are military combat survivors. And experts agree that in general, they believe these estimates are low because of underreporting. When you hear all these statistics and you understand our role in the healthcare profession, you can understand why we need to be aware of the signs of abuse, neglect, and PTSD. Let's start at the beginning, the developmental impact of trauma. Failure to grow up in a healthy, nurturing environment can lead to unhealthy tendencies. I have provided a video for you in the course content folder. Go ahead and watch that now and then come back. The chart on this slide will show normal developmental stages for personality, and on the other side, there you can see the potential tendencies and traits for personality dysfunction. Take a minute to read it over, but in short, you can see that a healthy, nurturing environment leads to someone capable of adaptive behavior versus someone who would grow up in a non-nurturing environment, tends to be more selfish, self-centered, and difficult with adaptation. What's your role? You are a mandated reporter. And what does it mean to be a mandatory reporter? Well, the law goes a little bit like this. Any person who is required to report, who knowingly or willfully fails to report any instance of suspected abuse, will be guilty of a misdemeanor. I have provided a link in your course content folder about mandated reporter training. It gives a lot of info and details, including the free training. There is one group that the law does not protect under this mandated reporter, and that's those who refuse to give medical treatment to their children for religious objections. Quote, "No child who in good faith is being treated solely by spiritual means through prayer in accordance with the tenets and practices of a recognized church or religious denomination by a duly accredited practitioner, therefore shall, for that reason alone, be considered an abused child." Some religious groups routinely reject some or all mainstream healthcare on theological grounds, including Christian Scientists, Jehovah's Witnesses, Amish, Scientologists, and some fundamentalist Christian churches. They believe that whatever happens is God's will. In most cases, the courts has sided with them to give them the right to make this decision for their children as well. They are often found not guilty. The literature is littered with manslaughter and murder cases or abuse cases due to lack of medical treatment because of religious objections. However, in any case where you believe that there is abuse and neglect, it should be reported. In Georgia, a PTA who fails to report elder abuse will be guilty of a misdemeanor. I've had to report senior abuse one time when I was working in home health. The patient was clearly neglected. I came home to her home and found her in her bed covered in urine and feces. She'd been left there for hours upon hours alone. It was awful. No one was home. I let myself in because she texted me that the door was open. She added that she needed help, which is why she was letting me know I could come in. She said that she had been afraid to say anything because she didn't want to lose her home. It was her family that was living with her that allowed her to stay in her home. And it's not like that. It was just the one time I suspected anything. I'd been seeing this patient off and on for around 2 months. She had had rehabilitation and then fell and went back to the hospital and was gone for a couple weeks, and then she was back on home health and I was seeing her again. And throughout the series of treatments, you just start to see more of the unraveling of the household. Like at first, it kind of seemed like a normal household, and then over time, you could really see it degrade into just it just became so obvious that there was so much neglect going on in this household. And that's how it happens too. It's rarely obvious from the get-go that there's abuse or neglect going on. People try to hide it, and it's only after prolonged exposure that it can tend to come out, that you can recognize that something isn't right, and eventually all the cracks begin to show and they get wider and wider. Psychological response to pain. Pain has been identified or defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. The nature of a person's suffering and their psychological response to that physical or emotional experience will be influenced by their past experiences, their culture, spiritual beliefs, and that is all clinically relevant to their physical pain. As therapists, we will be challenged to address not only the observable contributors to their pain to help improve their function and independence, but also deal with the unseen psychosocial emotional components of their pain. How is their psychological response to pain clinically relevant? Well, because some people believe, because of cultural reasons, that if they're in any pain, they shouldn't do anything at all. They should lay in bed until they're magically out of pain. And that is a belief that they have, and you'll find it with some of the older generation. I've seen it a few times with Asian culture. Or imagine the person that just is really scared to move and to feel any pain at all because they just have a low threshold for pain. They haven't experienced a lot of pain, and you ask them to do an activity and they're just afraid to do it. And the pain, their perception of what pain they might feel is holding them back. Our role here is just to educate them and comfort them and reassure them and guide them on the benefits of why we're asking them to do these things. And for me, that is one of the major reasons why you understanding the why is so important, because you should be able to explain to your patient the reason behind the activity you're asking them to engage in and give up their time to do, especially since many of these people may or may not be exercise people or have any desire to do those things. So but if they understand the why and you have the motivating factor, the reason, the thing that they desire, whether it's to continue to live alone or they want to be able to get on the ground to play with their grandchildren, you have to come up and find the reason why we can increase their compliance and we improve their motivation for the activity when they understand the benefit of the activity. Also, psychologically beneficial to make the activity just hard enough to where it's a little bit challenging so that satisfaction comes from being able to accomplish it. So you have to walk that line between it being too hard and it creating failure and feelings of inability, and finding that place where it's just hard enough to where it's kind of fun and then they overcome the challenge. Let's dive into some bigger issues like schizophrenia. There was a study that estimates between 5 and 28% of the general population hear voices that other people do not. Causative factors could be traumatic events, genetic inheritance, biochemical imbalances, and possibly environmental influences. Under the header of paranoid schizophrenia, we have delusions of grandeur and delusions of persecution. The delusion of grandeur. The grandiose type syndromes will include grossly exaggerating the beliefs of one's self-worth, their feelings of power. Maybe they have a grand idea about their brilliance and or their identity. They have an exceptional relationship with themselves. And they also may believe that they have an exceptional relationship with God or Beyonce, some other famous person. So that's the delusion of grandeur. It can be supported by auditory hallucinations. Then there is the delusion of persecution. This one is more common. This is the most common delusion when the individual believes that they're being tormented, followed, tricked, spied on, or ridiculed. They can believe that their food is being poisoned, so they believe everyone is out to get them. Both of these types of delusions can occur in individuals who also have bipolar disease, which I'll talk about here shortly. A catatonic schizophrenia is a different type of schizophrenic. They have motor disturbances as well. It presents as rigid posturing, and there can also be episodes of uncontrolled movements. These patients remain aware during these episodes. A disorganized schizophrenia is usually a progressive condition where they will just be mumbling sort of nonsense and having inappropriate emotional responses. I have provided some videos in your course content folder to help you get a better picture about these different types of schizophrenia. Though it is worth noting that these types of psychoaffective disorders don't always exist in a vacuum, and they can include combination of symptoms of schizophrenia and other mood disorders such as depression or bipolar. Go ahead and watch your movie time now. Feel free to stop any video once you feel you have an idea about the presentation. Somatization. Somatic symptom disorder occurs when a person feels extreme anxiety about their physical symptoms like their pain or their fatigue. They have intense thoughts and feelings and behaviors related to the symptoms, and they will interfere with their daily life. These patients are not faking their symptoms. The pain and the other problems are real. The pain could be caused by something that's physical, but it could also not have any physical cause whatsoever. It is an extreme reaction or extreme behaviors about their symptoms that is primarily the main problem. There are even several medical sources that say that there is no medical problem present. Somatization usually begins before the age of 30. It is more common in women than it is in men, and it's not clear why some people develop the condition. The factors that could be involved are having a negative outlook or personality, being physically and emotionally sensitive to pain or other sensations. It could be related to family history or upbringing and possibly genetics. This condition should not be confused with hypochondriasis. That's the condition where just someone obsesses about their health and imagines symptoms. Hypochondriasis is also a somatoform disorder, but hypochondriasis is just the fear of having a life-threatening illness or condition. Conversion disorder. This is also in the category of somatoform disorders. Conversion disorder is a mental condition where the person unconsciously develops symptoms that usually involve motor or sensory function that can't be explained by medical evaluation. So, for example, someone comes in with Parkinson's-like symptoms, but they don't seem to have Parkinson's. But maybe they've recently lost a loved one in their life, such as a spouse. So it can come from this mental trauma that can manifest into a physical trauma. The disorder consists of neurological symptoms or deficits that will develop unconsciously and non-volitionally, and they usually involve motor or sensory function. Paralysis has been the most common finding. Others are experiences like blindness, deafness, and paresthesia. The manifestations are incompatible with known pathophysiological mechanisms or anatomic pathways. What does that mean? It means it doesn't make sense why they're having these symptoms. Onset, exasperation, or maintenance of conversion symptoms is commonly attributed to mental factors like stress. So it's about managing stress and preventing stress and exasperations of stress. Diagnosis will be based on the patient's history after they've excluded any physical disorders as the cause. Treatment will begin by establishing a consistent, supportive physician-patient relationship, and psychotherapy can also help, as well as hypnosis. Anxiety disorder. Anxiety disorder will fall under the category of neurosis disorders. This refers to a group of disorders that exhibit fear and maladaptive strategies when dealing with stressful and even everyday stimuli. So they're not very adaptable. They have a lot of anxiety about situations that they're not comfortable in. Patients with neurosis are not dealing with psychosis. They do not have delusions, and they usually realize that they have a problem. Patients with anxiety just chronically worry. They're apprehensive and they overreact. So what is maladaptive behavior? It's things like stress relief through self-medication or cutting or sex addiction. There's several types: general anxiety disorder, PTSD, panic disorder, and OCD. The somatic symptoms are going to refer to the autonomic nervous system or to a specific organ system. For example, chest pain, maybe pelvic pain or digestive, bowel, bladder dysfunction. It could manifest as shortness of breath, palpitations. These kinds of things can occur on somatic symptoms. Anxiety can become self-generating because the symptoms that they feel will reinforce the reaction, which is going to cause a spiraling effect. Stimulants can also trigger anxiety disorders and can contribute to that spiraling effect. So people with anxiety or disorders should avoid things like cocaine and caffeine. And sometimes the stimulants that are used for treating asthma could induce that. Adjustment disorder. This is another common anxiety disorder, but it's usually a temporary phenomenon in response to a stress, like a traumatic injury such as a spinal cord injury, a motor vehicle accident, or burn. It could be from some type of change in the family system as well, like a divorce, loss of a job, loss of a home, moving, relocation. But it's most often associated with a chronic illness or a life-altering diagnosis. It's during this adjustment phase that the person will gather their resources to maintain their self-worth and to find acceptance and their ability to cope with what's going on. For some reason, this adjustment stage can become more of a maladjustment phase, and the person will remain unable to come to terms with their fear. They'll stay with disbelief, anger, guilt, or even depression. Any recovery from these feelings is going to remain hampered because of their real disease or their perceived impairment. General anxiety disorder. This is another common anxiety disorder. Anxiety is a condition defined as excessive, persistent worrying over an imminent event, such as a death, an illness, or even minor events, such as being late for an appointment or an uncertain outcome. The symptoms of general anxiety disorder can include fatigue, hypervigilance, restlessness, and irritability. And it's often a chronic state of being. They will focus on physical or emotional pain. They will either notice the pain more or interpret the pain as being more significant than what someone else might feel. They might also exhibit pain behaviors that are not necessarily warranted, like depending on their pain, like limping or grimacing. They might be medication seekers. This kind of behavior can lead to disability. Panic disorder. This is another common anxiety disorder. Panic disorder is characterized by periods of sudden, unprovoked, intense anxiety with associated hysterical symptoms. This will last for a few minutes, and it could last for a couple hours. The initial panic attack could develop during a period of extreme stress, such as after a surgery or a serious accident, maybe illness or a childbirth, just after some extreme stress. They're going to worry so much that they're going to have feelings of alarm, and that can generate in symptoms like shortness of breath, tachycardia, palpitations, a headache, dizziness, feelings of being smothered, nausea. All these things can come out of panic. They can all contribute to a feeling of impending doom. And to top it all off, some people, about 30% of people with panic disorders, have sleep panic attacks. These are not considered nightmares. It's a different thing. When they wake up from these things the next day, it is not uncommon for them to actually feel sore muscles after that type of episode. PTSD, another common anxiety disorder. The symptoms for this will usually begin within the first 3 months after the exposure to the stressful event or trauma. Originally, this was defined to include military combat, but the definition has definitely expanded. We now know a person does not have to directly experience the event to develop PTSD. For example, a healthcare worker dealing with the aftermath of violence or a natural disaster could develop PTSD. 911 people who answer phones who are far away from the events have also developed PTSD. It could be months or even years before the symptoms begin to occur. Intrusion. They are going to start to re-experience the trauma in distressing memories, or thoughts or nightmares, and this may include images or sensations. Certain cues will be known to trigger these events or thoughts or memories. Then you have avoidance. As avoidance continues, the person seems to be bored, cold, or preoccupied. But people with PTSD frequently say that they cannot feel emotion, especially towards those who they are closest to. And then that means that family members will often feel rejected because they are lacking affection and the individual is acting mechanically around them. So they're going to avoid the stimulus that could trigger their memories. And they can also have sleep disturbances. People with PTSD report an experience called emotional numbing, and this can be in response to positive or negative emotions. They may have survivor's guilt, especially if it involves someone close to them who perished. These individuals may exhibit increased arousal or hypervigilance that just wasn't there before their trauma. They have this increased autonomic nervous system response. So that's going to lead to nausea, dizziness, sweating, shortness of breath, and that high heart rate and high blood pressure. They will manage this with pharmacological agents like antidepressants, anti-anxiety meds, mood stabilizing drugs, and possibly antipsychotics if needed. And they've also learned to use exercise and psychotherapy. Obsessive compulsive disorder is another common anxiety disorder. Obsessions. They will have constantly reoccurring thoughts like fear of germs, and constant reoccurring thoughts. There's a compulsion. It's a repetitive ritual behavior that they cannot stop performing, like washing their hands. Originally, This was perceived as a need to control, but since it's been responding well to specific medications, it now suggests that there could actually be a neurobiological basis for OCD. People with OCD are unable to control irrational behavior, and it most commonly begins in young adulthood. So most people do not have OCD who love to say, I'm OCD about this. It's a cute saying, but I get it, but they do not have OCD. And I'd wager that if they said it around someone with OCD or someone who actually knows someone with OCD, it would seem really insensitive. Phobias. This is a common anxiety disorder. This is an irrational fear, and it will create difficulty for everyday life. There are many subclassifications, including agoraphobia, social phobia, and simple phobia. Um, Phobias may develop because of a traumatic experience. They can also be learned behavior from observation. So, careful what you do because your child may develop your weird phobias. And then, of course, classic conditioning. So, re exposure to something that has been traumatic or frightening, which is why some people have phobias of dogs. They've been bitten multiple times, things like that. Depression. This is an active disorder and it's classified by disturbances in mood or emotion. Depression is the most common adult psychiatric disorder. It can begin at any age, but the average onset is the mid-20s. The predisposing factors could be genetic, familial, biologic, or even psychosocial. Patients will report a morbid sadness, a feeling of dejection, or a sense of melancholy, which is distinguished from having grief. Grief is a normal response to personal loss. Depression is not grief. It's important to recognize that mild or sporadic depression is pretty much a common phenomenon experienced by almost everyone. But to feel sad and empty and hopeless most of the day, nearly every day, that is not normal. Depression can result in trouble sleeping, eating, and people just lose interest in pleasures and hobbies or being friends or seeing family. It's not normal. If these symptoms are present for at least 2 weeks, they could be consistent with depression. Depression is associated with a physical illness, and it is treated in several ways. One way is ECT, which is a shock therapy. It'll use an E stem to provoke a controlled seizure inside the brain to affect the brain in the same way as an antidepressant. Though it doesn't sound like it, it's painless and apparently safe. The ECT is used when the patient's condition is not improved after they've been taking medication, or if they're suicidal, they're engaging in self-mutilation, maybe they're catatonic, or they're just unable to eat and function, they will try it. Bipolar disorder is another active disorder, and it is considered one of the most complex disorders in psychiatry, with multiple phases and varied presentations in each of these phases. This makes diagnosis and treatment very difficult. Bipolar is characterized by a cyclic mood swing, and it can include outbursts of high energy and elevated mood, as well as decreased need for sleep, and they have the scurry, like a ton of ideas. And this could be followed by extreme depression. And you can imagine how that could be hard to medicate. So each phase could last for days to months, and it'll switch back and forth with normal periods, and then they'll have periods where they're more normal in between. Bipolar disorder can manifest as manic episodes with or without depression. It can also manifest as depression with a less severe form of mania. It's hypomania. Bipolar disorder is often associated with heightened creativity and creative talent. Suicide risk. Of those with bipolar, 25 to 50% of them will attempt suicide at least once. It is the leading cause of death among young adults aged 15 to 24, and especially in the subgroup of college students. All suicidal thoughts and acts must be taken seriously, and we need to respond appropriately. Read through this list of risk factors for suicide. The QPR suicide prevention. It's not intended as a form of counseling or suicide prevention. We are not psychologists any more than we are doctors. But the QPR is for screening, and it's a preventive tool to help assess warning signs of suicide. Studies have indicated that asking questions about suicide does not increase the risk of suicide attempts or success. Q is for questions. You will ask them if they are suicidal and just ask some general questions that you feel seem appropriate at that time. P is for persuade. You're going to tell them about the benefits of speaking to someone, and R would be for refer them to help. You will actually provide someone who can help them so that it's not just empty words. Management of escalating patient behavior. I don't want to scare anybody out there, but not everybody acts like a good person when you work with them, especially in settings like acute and SNF, where you will see mental disorders or people coming off of drugs, alcohol, and their behavior can be violent. So let's talk about how we manage or we de-escalate this type of behavior. I'm not making excuses for anybody, but imagine the financial stress, the social stress, the physical and mental stress that comes with a serious injury or illness. It can be frustrating enough to cause even mild-mannered people to become agitated or even combative. When dealing with these types of situations, we should be respectful in our attempts to de-escalate. We also need to be mindful of maintaining a safe environment for everyone involved. Many facilities are going to offer training in nonverbal de-escalating techniques, and this will be helpful in diffusing a potential threatening situation. Understand that attempting to reason with an escalating patient can actually make things worse, and that a calm reasoning in a threatening situation is counterintuitive to our own fight or flight response that could be occurring. So successful nonverbal de-escalation requires the provider to maintain that self-control and a protective yet non-threatening physical presence. Sounds easy, right? There's going to be a lot of negative energy coming your way, and you have to maintain control and calmness without attempting to reason with them. You have to be able to be ready to protect yourself while still appearing non-threatening. You also need to be aware of the supportive resources for where you're at, including the option to leave the area if necessary. Here are some important tips. Keep your hands out of your pocket so they're ready for self-protection, but it also avoids the appearance of you trying to conceal something. ETOH patients are a prime example of this type of behavior. That is alcohol abuse. It's so bad, it's like they've boiled their brain in alcohol. And when they're coming off of it, they're confused, they're violent, and they are aggressive. Early on, when I was working in the hospital, I had an ETOH patient, and I had never experienced this while I was on clinical. And he was an amputee, and they had his below-the-knee amputation. His prosthesis was in the security, so he didn't have it available to him. So my job was to go in and get him up and get him moving, and try to get him in the chair. And he's being pretty aggressive with me. And I stand him up, and he is pushing forward and all of his weight into me as hard as he can, trying to shove me over. And it's because he doesn't understand that he's also going to fall over. Like, his brain is not working right. So I stand him up, he's pushing into me as hard as he can, and I can't figure out why I can't get him away, because he's got one leg. And so I look, and he's pushing with his residual limb into the hospital bed, and he's using that as leverage to get his whole body to just push forward into me. And so that's the day I had to leg sweep my amputee patient to get him to sit down. And um, I learned a lot about ETOH the hard way. So when you are with someone who is exhibiting any signs of aggressive behavior, it's just best to defer therapy and move away from that situation. I think it was about 24 to 48 hours later, his brain had cleared enough to where you could talk with him and reason with him, and he still wasn't a particularly pleasant person, but he was safe for therapy. So sometimes you just have to wait until the drugs have worn off or the alcohol's worn off or whatever it is that might have induced their state of aggression. And other times, it's just not appropriate to work with them. They may always be aggressive and always be dangerous. Pharmacological management. Things we have to be concerned about with medications for psychological disorders is sedation. And PT can work with implementing alternate methods to decrease their stress and anxiety, and that would be exercise, physical activity, massage, and relaxation techniques like deep breathing and stress management or meditation education. Anti-anxiety meds will target dopamine and serotonin within the brain. These are things like Valium and Paxil. Antidepressants will seek to normalize neurotransmission activity. Those are things like Prozac and Lexapro. Antipsychotic medications. These will work to block dopamine receptors. There are side effects such as tardive dyskinesia. That means involuntary repetitive body movements. In this form of dyskinesia, these involuntary movements are tardive, as in meaning they have a slow or belated onset. This condition usually occurs because of long-term use for 3 months or more, or there's been a high dose of these psychoactive drugs. Pseudo-Parkinsonism is a long word with an even longer definition. It manifests as apraxia, in slowness, difficulty with motor planning to perform tasks or movements, and there will be a peritonic rigidity, which is an increase in the muscle tone at rest. This is characterized by an increased resistance to passive stretching. They may also have the presence of a frontal gait disorder. That's an imprecise term that just describes the combinations of findings that's seen in patients with cerebral disorders. So it's just disconnected ataxic. There's elements of akinesia, which is the loss of their voluntary movement. And taken together, it can really look like true Parkinsonism, but it's not. The common antipsychotic drugs are Haldol, Thorazine, and Abilify. Pharmacological management of bipolar conditions. Bipolar medications will contain lithium to stabilize the mood. It's a sedative hypnotic agent, and it can have serious implications for physical therapy. It's a sedative. So what should we be concerned about? I'd say falling. Falling is something we need to be worried about. They're going to just be a little sedated and have slow reaction times. Another side effect is anterograde amnesia, which is the loss of the ability to create new memories after the event that caused the amnesia. This is going to lead to partial or incomplete ability to recall their recent past. but all their long-term memories from before they had the traumatic event will remain intact. It's really important to recognize the stigma around mental health disorders. I mean, immediately after I got my medication for schizophrenia, my friends stopped talking to me. Okay, that's all, folks.